Hey Doc, it's Nick. We have a patient here that you had obtained a CAT scan, and we want to take a look at this together just to confirm what I believe it was a periodontist had recommended an extraction for. So tooth is number 12. I'm still learning how to use the software, so this sagittal view here is actually mirrored. So this is number 15, 14, 13, and 12, and here's the tooth in question. The clinical observation was class 3 mobility with an 8mm pocket, which the specialist had confirmed was suggestive of a cracked tooth requiring extraction. So the CAT scan is helpful because it gives us confirmation on the diagnosis, but it really gives us an entire additional layer of information to help us treatment plan the case moving forward. So first and foremost, when I see periapical radiolucencies on a CAT scan, very similar to a two-dimensional PA, I'm going to ask the question, is this widening of the PDL or is it a periapical abscess or periapical radiolucency suggestive of a necrotic canal? And this kind of uniform look around the root tip, which I see in the sagittal view, but also this transverse view, is rather uniform, which gives me a sense that this tooth was under a certain degree of occlusal microtrauma over time. And it would make sense that an upper premolar, which we've seen, crack, they're a common tooth to fracture in an oblique way, when the occlusal trauma is high, is corroborated by the fact that this tooth appears to have been under this microtrauma over time. This is definitely not what's causing the class 3 mobility, in great part because the bone around it everywhere else looks good, with the exception of the deep pocket. So this is just evidence of what led to the problem, not the problem itself. So I'm going to come to this view over here. What I'm looking for is the bone around the tooth. I'm trying to get a sense of, is there a obvious loss of bone that would correspond to where the deep probing was. Not knowing where the probing is, I'm just assuming that I'll see it somewhere around the tooth. So if I had done the probing, I would be looking specifically in the area where the probing happened. But let's just take a look, see if there's anything obvious that jumps out at us. For some reason, it wants me to alter the brightness and contrast. Let's see here. Click and drag on a viewer to adjust the brightness and contrast. Right click to finish. There we go. Okay, sorry about that. So I'm looking around the tooth here, and this looks very normal. This looks a little widened. We've lost the cortication of bone around the palatal part of the tooth, but at this level that's not uncommon. And as we go more apical, it really appears normal all the way around. The fact that we have a bifurcated canal, this suggests to me that the tooth is at higher chance for a fracture in this dimension here, so I'm keeping a closer eye on that. But I just don't see bone loss that corresponds to class 3 mobility and an 8mm pocket, especially as we go apical. So from this point forward, this looks very normal to me. And it's not until we get to right about here, which is very close to the apex, that we start to see that widening of the PDL that speaks to me as occlusal microtrauma over time. So what I did is I came back more coronal, and I looked with a more discriminate eye, and then I saw this. So this fracture, or what looks like a fracture right here, that corresponds to a radiolucency, could be the area of focus. And if I was to measure, let's see where that pocket stops. Kind of in this area here to the gingival margin, which is kind of right in this area. Let's just do a measurement and see what we get. Yeah, I'm not able to make a measurement. Still learning how to use the software, but to me that looks 7 millimeters. You know, so we're in the ballpark of what the specialist had recognized as a deep probing. So we can surmise that this is the crack right here. Let's take a closer look at it. Anyways, this is the line right here. If the deep probing was indeed that spot, then I would be relatively confident that this is the oblique fracture that we see in the CAT scan. If the deep probing was somewhere else, then I would be second guessing our diagnosis and recommended treatment. So based on your observation, was the probing kind of in that distal lingual area, and was there any deep probings in the kind of the mesial root and cavity part of that upper first premolar? What is the endo testing? I think it'd be helpful to know what the cold testing showed, because if this tooth is actually still vital, it further suggests that this is a cracked tooth. So that's about it. I know the patient is heading back to the specialist. This is a great site for an implant, plenty of bone, so a socket preservation here would do us very well. If it's already been planned by the specialist, then we'll let them continue with that. But we have a lot of options here. I think the lesson here is just the occlusion. So the occlusion likely led to this tooth's demise. Whatever we build in this spot, or even if we do nothing, we have to understand that the occlusion was not balanced. Therefore, a tooth paid the price of that imbalance. Do we want to present to the patient equilibrating he or she to get them out of this pickle? Of interesting note, just the bone loss on the distal buccal root of number 14 and the furcation involvement. This speaks to me as a tooth that probably had some periodontal therapy in the past based on the flatness of the bony architecture. So my guess is this is actually a stable site, but with the CAT scan we often see things that are not very obvious on periapical or bite wing films. So bringing a little bit of attention to this area too might be of help for the patient. So let me know if I can help any further. Looks like the patient benefited from the CAT scan by being able to confirm the presence of a crack. Take care.